Please go ahead.
Thank
Kindly
you.
go ahead.
Sure, sir. Uh, with the kind permission of our respected program directors, I'm Dr. Manoj Kumar. It's my honor and privilege to welcome you to Secrets of Neurology, a knowledge feast for all neurologists. This is the ninth episode. That means it is running every month since last 9 months, and this has been hugely appreciated by all the DM and DNB students and fellow neurologists across the country. A very, very warm welcome to Dr. Sudhir Shah and Dr. Lakshmi Narsimhan, and a great word of appreciation for both of you for pulling it off for almost 9 months and still going strong, sir. I would also like to have a warm welcome to the faculties and the discussants today. I know and best wishes for your presentation today. The program normally lasts for 1.5 hours. It's my honor and privilege to welcome our program director. Sir, happy Holi to you. All of us know you very well, Professor and Head of Department of NHL, MMC, and SVPI MSR, Ahmedabad, Director of Neuroscience, Sterling Hospital, Ahmedabad. Sir, the world reads all the 6 books in the field of neurology. Because of your work in the field of patients' care, society at large, and contribution to neurology, you have been conferred prestigious Padam Shri by Government of India. Dr. Sudhir Bhai Shah is also a recipient of B.C. Roy Award, recipient of Yona Award, many interviews, publications, and he has produced many wording laurels and scholars. Interest is stroke, neurodegenerative disease, and epilepsy. Thank you, sir, for doing the honors. A very warm welcome to our program director, Dr. Lakshmi Narsimhan. Sir, all of us know is director and professor of Institute of Neurology at prestigious Madras Medical College, the same institute from where he started as a student and is now heading the department. Many awards and accolades to his credit, but I'll be brief. Recipient of A.B. Baker Award for Global Best Teacher, Best Paper Award by American Academy of Neurology, and many more to his credit. Three-term executive member of Indian Academy of Neurology, CME convener multiple times. Sir's areas of interest are varied, and thank you very much, sir, for doing the honors. Over to you, sir, Program Director, Dr. Sudhir Shah and Dr. Lakshmi Narsim.
Thank you. Thank you very much, Dr. Manoj, for that kind words of introduction. And herewith, I welcome all, particularly my program co-director, my personal friend, Dr. Lakshmi Narsimhan. I also want to profusely thank and welcome Professor Madhu for accepting this invitation to conduct today's series, that is episode 9 of Pulse of Wisdom, Secrets of Neurology. And also thank and welcome all other speakers and presenters for the program. Now, as has been mentioned, this program is very well received across India. Lots of students of DM and DNB neurology, fresh uh, neurologists, as well as some senior neurologists, they all alike, they have appreciated the format of this program. With the vision of Professor Madhu, this time we have changed the format for the first time, and it's kind of a CPC-like discussion. I'm sure you all will really appreciate this format also. So, first of all, I must thank all the attendees for their patronage, their continuous trust in us, and logging in every time and learning the basics of neurology. As you know, we are now more getting accustomed to MRIs and reports, and the clinical neurology is getting the back seat. That's our biggest mistake, and I want, we, myself and Dr. Lakshmi were very keen that all of us, particularly the students and those who have freshly passed neurology, should relearn the clinical neurology by each. So with that intention, we have launched this program. I want to thank Intas Pharmacy, particularly Mr. Chacha and his team, for giving a lot of logistic support for this program. And my special thanks to my dear friend, Dr. Lakshmi, who is working very hard to make this program more and more successful. With that word, I want to invite Dr. Lakshmi to take over the proceeding further. Thank you. Dr. Lakshmi, please.
Hey, Manoj, may I have the next introduction slides, please?
Sure, sir.
It's my great pleasure to introduce Dr. Srivardhan, who is a resident in my department, Madras Medical College, and is one of our outstanding students. And he has contributed in all my endeavors in Dijon, Paul Brazes, and Biller. My sincere welcome to you. Next slide. Dr. Ashwathi Sasidharan, who's from the Pushpagiri Institute of Medical Sciences and Research Institute, Tiruvalla. When I said, sir, I need a resident, Dr. Madhu sir immediately said the name of Dr. Ashwathi Sasidharan. That itself speaks volumes about our clinical skills, because a doyen like Dr. Professor Madhu points out somebody for discussion. That means we expect quite a lot of things from you. May I have the next slide, please? Dr. Uma Mageshwari, she's an alumni of Madras Medical College and is life member of Indian Academy of Neurology and Indian Epilepsy Association. She has a lot of presented papers at various national conferences, published original articles in International Journal of Neurotuberculosis. Interest is demyelinating disease, stroke, epilepsy, and she's part of the demyelination clinic and also the muscle and nerve clinic and in our institute. And she will be dealing with the recent advances pertaining to this diagnosis. Next slide, please. My greatest welcome and namaskarams to Professor Madhu, whom I am his ardent fan all through my career. And I have whatever neurology I know is many a times whenever I get into trouble, I always go back to him. He's a walking encyclopedia of neurology. I would rate him as one of the topmost clinicians in neurology in the country, and must be in my rating is must be in the top 3. So my current affiliations are sir as Professor and HOD of Neurology, Travancore Medicity, Adjunct Professor of Neurology, Manipal University, Manipal, Senior Consultant Neurologist in PR Hospital, Trivandrum, Professor Emeritus Medical College, Trivandrum, former Professor and HOD Medical College, Kottayam, 36 publications and national and international journals, contributed 15 chapters in textbook of neurology, and published a book on higher neural functions, which I insist that every neurology resident should read that. This book was co-authored by one of my another great neurologist, Professor Anand, and awards winner of the Epen Samuel Award for the best research work, awarded the lifetime achievement by the IAN. Controversies to consensus neurology in the year 2014, was awarded the Master Teacher Award in the Shine, and awarded the Lifetime Achievement Award by the Neurological Society of India, Kerala chapter in February 2020. Sir breathes neurology, eats neurology, drinks neurology, lives neurology. I welcome you, sir. Welcome you, sir, for this episode. And next slide, please. Now I hand over the proceedings to the Dr. Srivardhan to take over.
Is my screen visible, sir?
Yes, go ahead.
Yes, sir. At the outset, I would like to thank the organizers of this meeting as well as the project coordinators, especially Professor Dr. Lakshmi Narasimhan for having given me this opportunity to present in this podium in front of the doyens. I also thank the faculties and my colleagues in the Institute of Neurology, Madras Medical College, who have helped me in working up the case. So to start with the presentation, the patient is a 54-year-old lady hailing from Chennai, a right-handed individual. The history was provided by patient as well as her daughter. She works as an housemaid and she has no formal education. Her chief complaints included difficulty in looking down for the last 1.5 months, irrelevant talking for the last 2 weeks, and episodes of vacant stares with lip smacking for the last 2 weeks. A history of presenting illness. The patient was apparently normal till 1.5 months back. One day while cooking, she dropped an utensil. When trying to reach for it, she noticed that she had difficulty in seeing objects below and had to use her hand to run over the floor to pick the object. She then realized that she had difficulty in looking down. She tried looking at herself in the mirror, had no issues. When she informed her daughter noticed that her eyes did not move down properly. This visual complaint was not associated with any blurring of vision or diplopia. She did not describe any sensation of a curtain falling from below up or from above downwards. The symptoms have been static since and has not responded to any medicines. She met a nearby doctor who advised certain spectacles, but there was no response to that. Over the next few days, the patient complained of occasional giddiness, not associated with true vertigo, not triggered by any particular position. The symptoms persisted for almost a month and she stopped going to her household activities, but she was able to cater to her daily needs and do her normal household activities. She also gives history of bumping into or running over objects in the floor or ground as she fails to see them. Over the last 2 weeks, her daughter noticed that the patient started having the following symptoms, which included irrelevant talking, history suggestive of visual hallucination, tending to confuse between her two daughters, and history suggestive of memory loss with a tendency to forget the names. The irrelevant talking was in the form of giving irrelevant responses to a question. She would start telling events which happened several years back when asked about something else. She also had a tendency to tell complicated stories when asked what she did a few years back, which was invariably incorrect. She never was found talking to herself or talking without having any questions asked or behave like talking to a wall or a vacant space. The daughter also complained that at times her mother would point to an empty space and ask why that person is standing over there. Mostly her description includes people who are either alive or dead. When explained that the person was not there, she would be convinced. She always had a tendency to see formed images like person or animals. There is no history suggestive of visual distortion, flashes of light during such episodes. She also used to get frequently confused between her two daughters and she would mistake the elder one for the younger one and vice versa. When corrected, she would agree. Once she was inquiring her younger daughter about her grandson, when actually she had only granddaughters but no grandson. The daughter also mentions that there are 2 or 3 episodes of vacant stares, each lasting 3 to 5 minutes, associated with lip smacking or tongue protrusion with a stereotypical grinding or mixing movements of both hands. During those episodes, the patient would be non-responsive and then she would immediately regain her consciousness and tend to not remember the event and would continue her activities as usual. All these symptoms develop progressively over the last few days and are persistent. However, she was able to continue her routine and daily household activities. There was no history suggestive of any behavioral changes. She was able to cook normally and did not commit any errors during the procedure. She was optimally taking care of herself and her self-hygiene was normal. There was no history suggestive of increased anger outburst or obsessive behavior. There was no recent history of any change in dietary practices or history suggestive of food faddism. There was no history suggestive of hyper-religiousness. Daughter gives no history of tremor, postural abnormality, tendency to fall, slowness of activity, or abnormal gait. Over the last few days, the daughter noticed that she always feels sleepy and tends to sleep at any time. There is no history suggestive of any alteration in the sleep-wake cycle. In spite of sleeping, the patient feels the quality of sleep as being poor and non-refreshing. There is no history suggestive of snoring during sleeping or dream enactment behavior or any other abnormal movements during sleep. Even though the patient always feels sleepy, she hasn't fallen asleep without her knowledge any time while performing an activity. There was no history suggestive of any total loss of consciousness, impairment of smell or taste, facial or bulbar weakness or limb weakness. There was no sensory complaints. There was no history suggestive of any diurnal variation or fatigable visual complaints. No history of vomiting. No prior history suggestive of any visual complaints. There was no bowel bladder involvement. No history of tinnitus, vertigo, or oral fullness, or features suggestive of generalized tonic-clonic seizures. There was no history of swaying to sides. Patient did not have any fever, weight loss, or loss of appetite or generalized fatigue. There was no prior history of significant head injury. There was no history of any recurrent oral or genital ulcers, dryness of eyes, photosensitivity, skin rashes, joint pain, early morning stiffness, or prior history of abortions. Patient is a known case of diabetes mellitus on oral medications. She has attained her menopause. There is no prior history of any surgery or significant hospitalization. No recent history of immunization, diarrhea, or constitutional symptoms. And there is no family history of similar neurological complaints. To summarize the history, we have a 54-year-old lady with no significant past medical history except for diabetes mellitus, who presented with a progressive neurological illness in the form of difficulty in looking down with a tendency to bump or run over objects for the last 1.5 months, associated with confusion, memory impairment, confabulation, formed visual hallucination with increased sleepiness, and history suggestive of focal seizure with impaired awareness.
Ashwini, you can take over. You are muted. Can you unmute Ashwini?
Sir,
Lakshmi,
shall I share the screen?
Lakshmi, can she
Sir.
go ahead?
Yeah, please, ask her to
Yeah.
start.
Yeah.
Start the discussion.
Yeah.
Good evening, teachers and colleagues. Thank you, Madhu sir, for giving me this great opportunity. I would like to discuss the case. So the chief complains a 54-year-old lady presented with 1.5 months of difficulty in looking down and 2 weeks history of irrelevant talking and episodes of vacant stares with lip smacking. Coming to the first complaint, she had difficulty to see objects below. That would point to a downward gaze palsy or to a bilateral altitudinal hemianopia. But this would seem less likely because we may have to implicate superior banks of both the occipital lobes. So I'll keep the possibility of a downward gaze palsy in the first concern. And then her daughter noticed that her eyes were not moving down properly, and she had no problem in looking at herself in the mirror or in any other instances. So this again points to the possibility of a downward gaze palsy more plausible. Now coming to the next symptom, she had complained of occasional giddiness, which were not associated with true vertigo. So again, patients with gaze palsy can have occasional dizziness, and this symptom can also be very well seen with patients who have diplopia, but that giddiness would be disappearing by closing one eye. So in this instance, we can consider this as a giddiness associated with the gaze palsy that our patient is having. Now coming to the next symptom. For the last 2 weeks, she started having irrelevant talk. She had visual hallucinations. She used to confuse between her 2 daughters. She had memory loss and tendency to forget the names. So the first symptom, irrelevant talking, it could be due to a perceptual abnormality as in delirium, or it could be a part of jargon speech as we see in Wernicke's aphasia, or it could be the patient. It could be that the patient was confabulating. The next one is a visual hallucination. It is a visual perceptive disorder. And the next one is she used to confuse between her 2 daughters, again a visual perceptive disorder. Then she had memory loss and tendency to forget the names. It could be due to a true memory problem, or it could be due to a nominal aphasia as such. Because it is topped up with a memory loss, we are not sure whether the patient has a difficulty to forget the names or is it a nominal aphasia itself. Or another possibility, it could be a part of delirium. Now, the history suggested irrelevant response to questions given in the question. Events which happened several years back when asked about a certain thing. Here she is filling a memory of memory, and this points to a momentary confabulation. And she also used to tell complicated stories when asked what she did a few hours back, which were totally incorrect. That is suggestive of a fantastic confabulation.
1 minute.
Sir.
Actually, the slide was not
Sir.
visible. The last slide. Go back to the slide once again. You can explain that confabulation. But yeah, go back
Sir.
one from the very beginning. You can talk that one. That's
Okay,
right. There was some connection error, so many people could not hear that.
Okay, sir.
Okay, yeah.
She used to give irrelevant responses to questions. She would start telling events which happened several years back when asked about a certain thing. She is filling up the memory loss of recent events from the fragments of intact past memory. This points to a momentary confabulation. She also used to tell complicated stories when asked what she did a few hours back, which were totally incorrect. That would point to a fantastic confabulation. And this suggests a frontal lobe pathology or its subcortical connections with basal ganglia and thalamus. She never was found talking to herself or without having any questions asked or behaving like talking to a wall or a vacant space. And that suggests it is not a perceptual disorder like delirium. Then she would point to an empty space and ask why that person is standing there. And mostly her description included persons who are alive or dead. This suggests visual hallucinations. And when explained that the person was not there, she would be convinced. That again suggests it is a visual hallucination with retained insight. So she always had a tendency to see formed images like persons or animals. There is no history of visual distortion, flashes of light during such episodes. So this is a formed visual hallucination with good insight. And we have many differentials for these symptoms, which include peduncular hallucinosis, migraine, but in the light of this, I would consider the possibility of a peduncular hallucinosis first. She used to get frequently confused between her two daughters and would mistake the elder one for the younger one and vice versa. This would be a person misidentification from a mismatch of new perceptions with past memories. She also asked about her younger daughter about her grandson once, but she actually has two granddaughters but no grandson. This is pointing to a memory loss with confabulation. And there were episodes of lip smacking or tongue protrusion with stereotypical grinding or mixing like movement of the head, and the patient was unresponsive, not responsive during these episodes.
1 minute.
Sir.
1 minute. A lot of people have said that the audio is not good. Mr. Chadda, can you do something? Hello? Haley?
Sir, I have stopped her video, so that should divert the bandwidth to her audio. So not a problem, sir. I think.
Okay, yeah, now it is okay. They've said. Fine,
Yeah.
please go ahead.
Sir, shall I proceed?
Sorry, yeah, please. Sorry for the.
Okay, sir. So she had episodes of lip smacking or tongue protrusion associated with a stereotypical grinding or mixing like movement of the hand. And during these episodes, patient would be non-responsive. These episodes were suggesting a complex partial seizure. And then the history was suggesting a normal dorsolateral prefrontal lobe with no evidence of any executive dysfunction. There were no history of any behavioral change, no obsessive behavior, no food habits, and there was history of any history suggestive of orbitofrontal or limbic system involvement. There were no history suggesting features of Parkinsonism. She had no history of tremor, postural instability, tendency to fall, or abnormal gait. The symptom was that of excessive drowsiness. So, focally producing excessive drowsiness would be seen in mesencephalic, diencephalic lesions like thalamus, hypothalamus, and pons. And now coming to the rest of the negative history, there were no history of any bulbar weakness, limb weakness, sensory symptoms, vomiting, head injury, fever, weight loss, bowel or bladder symptoms, etc. Coming to the past history, she is a known diabetic on oral medications and had attained menopause, and rest of the past history is unremarkable. So, to summarize, this is a subacute progressive illness of 6 weeks duration. The main symptoms were downward gaze palsy, which points to a dorsal midbrain etiology, hallucinations, probably peduncular hallucinations, recent memory loss with confabulation, most likely diencephalon involvement, thalamus or hypothalamus, excessive sleepiness, again pointing to a diencephalon involvement, fantastic confabulation, which points to a frontal lobe or its connection with basal ganglia and thalamus, and complex partial seizures. So putting it all together, the final site of lesion includes midbrain, diencephalon, and the adjoining medial temporal lobe. Now coming to the etiological differentials, my first differential would be a mass lesion. The second one would be a paraneoplastic brainstem encephalitis like anti-MAR2, anti-WHO. The next possibilities are a cerebral Whipple's disease, disease, and neurobursitis. Sir?
So yeah, you finished your history analysis. So even then you can go to the, anyone can, I don't know the pattern. Let me,
you'll continue the presentation, sir.
Okay.
Srivardhan will continue the findings.
Okay. Okay, then Srivardhan ask you, Srivardhan to continue the presentation.
Ma'am, can you stop sharing your screen?
Sure,
Yeah.
sure. Sure. I have stopped.
Is my screen visible, sir?
Yeah, yes.
So coming to the examination findings, in general examination, the patient was conscious and comfortable, normally conversing, afebrile, her vitals are stable. Head-to-toe examination reveals no significant abnormalities, except for the neurological findings, which I'm going to list later. There are no oral or genital ulcers, skin rash, or polyarthritis. No other system examinations are normal. Coming to neurological examination, to start with iron metal function, in the MMSE, patient had no formal education and she doesn't know to read or write. So leaving those two domains, she was eligible for the remaining 28 score, and she scored 15 out of 28, losing points primarily in orientation, attention calculation, and recall. And she was not able to recall even after giving cues. And copying was impaired. I'll show the picture later. Coming to frontal lobe, trail A and trail B tests were normal. 3-step motaluria and graphicluria were normal. Lexical fluency and go-no-go tests were impaired. Abstraction and proverb interpretation was normal. Digit forward was 7 and digit backward was 3. TAPE test, she was able to perform normally. In the frontal assessment battery, she scored 10 out of 18, primarily losing points in go-no-go test and lexical fluency. Coming to parietal lobe functions, there was no evidence of impaired cortical sensation. She had no apraxia. Calculation was impaired. She was only able to do simple calculations like addition and subtraction involving a single digit number. Previously, patient was able to do calculations involving 2 or a 3-digit number. She used to deal money in a family and she used to correctly get the change when she goes to shop. There was no dressing apraxia. Construction and drawing was impaired. There was no feature suggestive of neglect. So this is the construction assessment on giving a Nichols cube. This is how the patient copied it. There was a total distortion of the 3-dimensional orientation to the Nichols cube. Coming to a clock drawing test, she was able to put the circle normally. She was not able to fill the numbers properly, and she did not even attempt to put the time properly. And in an attempt to copy the intersecting figures, she was not able to do it perfectly. This was the copying which she did. Coming to occipital lobar functions, she had no aperceptive or associative agnosia. Face recognition was normal. Color vision was normal. There was no simultagnosia, optic ataxia, or oculomotor apraxia. In the history, there are features suggestive of formed visual hallucinations. Coming to the language domain, fluency, repetition, comprehension, both simple and complex commands are normal. Naming was normal. There are no paraphasias. Writing could not be assessed. Reading, she doesn't know to read, but she reads numbers, which she was able to do properly. Grammatism and syntax were normal. Coming to the memory domain, digit forward was 7 and digit backward was 3. In the recent memory, she was able to recall what she had for breakfast correctly. She was not able to retrieve a story. She was not even able to attempt what the story was about, and visual memory was impaired. Paired associative learning was impaired. Recall was impaired. It did not improve with cues or even with options. Remote memory was preserved. Semantic memory was preserved. Coming to cranial nerve examination, cranial nerve 1 was normal. In cranial nerve 2, visual acuity, color vision, and pupils were normal. Pupils are bilateral, 3 mm and reactive. Visual field was normal by confrontation method. Fundus examination was normal. Coming to 346 examination, lid was normal bilaterally. Among the extraocular movement, the vertical gaze was impaired. Down gaze was more impaired than up gaze, and this vertical ophthalmoparesis was maneuverable. The horizontal gaze was normal, and up gaze was preserved during attempted eye closure. That is, Bell's phenomenon was present. There are no nystagmus. Coming to saccades, the saccades were impaired and almost absent in the vertical, while it was normal horizontally. Coming to the perceive movements, the perceive movements were impaired vertically and it was normal horizontally. Coming to optokinetic nystagmus, the horizontal optokinetic nystagmus was normal. In the vertical optokinetic nystagmus, when the strips were made to run upwards, there were no perceive or corrective saccadic movements. When the strips were made to run downwards, there was a slow drifting perceive movement without a corrective saccades. Sir, shall I show the video now, sir?
Yes.
Sir, is the screen visible? This is assessing a lateral gaze. She was able to do normally to the right and left. This is Bell's phenomenon. Attempted eye closure, she was able to move her eyes up. On asking her to voluntarily see upwards, there was some impairment. And this is on asking her to see voluntarily down. She was only able to see in the horizontal direction. Again, she was having difficulty looking down. This is okay with the strips running towards the left side, sorry, right side, with the corrective nystagmus to the left. This is okay with the strips running towards the left side, with corrective nystagmus to the right. This is okay with the strips running upwards, vertical okay with the strips running upwards. There is neither a saccadic perceive movement or a corrective nystagmus in both the eyes. And this is a vertical okay with the strips running downwards. There is a slow drifting movement which brings the eyeball down, but the corrective saccades are absent. Coming to the rest of the cranial nerve examination, fifth nerve sensory and motor examination was normal. Jaw jerk was normal. Seventh nerve was normal bilaterally. Eighth nerve, the auditory and vestibular components were normal. 9 and 10, uvula was central. Palatal arches were normal and symmetrical. Gag was present. 11th nerve was normal. 12th nerve, there was no deviation of tongue, no wasting, fasciculation weakness, no macroglossia. Motor system examination, tone and bulk were normal bilaterally. Power across all the joints were normal, both in the upper limb as well as in the lower limb. Coming to superficial reflexes, corneal, conjunctival, gag reflexes are normally present. Abdominal reflex was absent in all quadrants. Plantar was flexor response. Coming to deep tendon reflexes, all the deep tendon reflexes are normally present. In the primitive reflexes, patient had bilateral palmomental reflexes. Rest of the release reflexes were not seen. Patient had no objective sensory deficits. There are no cerebellar signs. Extrapyramidal system was normal. There was no evidence of any autonomic dysfunction in the bedside. There was no orthostatic hypotension, restrict tachycardia, or abnormal sweating patterns. She had no signs of any meningeal irritation. Examination of the spine and cranium was normal. So to summarize, we have a 54-year-old lady who presented with progressive neurological illness in the form of difficulty looking down for 1.5 months, memory impairment, confabulation, formed visual hallucination, increased sleepiness with history suggestive of focal seizure with impaired awareness, and examination revealing impaired frontal lobe functions, impaired recent memory and recall, impaired constructional abilities with a vertical gaze impairment, predominantly saccades, down gaze more than up gaze, with normal motor and sensory functions with no evidence of autonomic, cerebellar or extrapyramidal dysfunction.
Actually, you can come back and
Sure.
discuss the findings.
So coming to the examination, general examination was quite unremarkable. Now, higher mental functions, she had a MMSE of 15 out of 28 with marked impairment of orientation, attention.
1 minute, ma.
Sir,
Dr.
sir.
Venkama madam has asked, what about the gait? Srivardhan?
Yes, the gait was normal, sir.
Okay.
She only had a tendency to bump into the objects on the floor, sir. Otherwise, her gait was normal.
Okay.
She had a impairment of orientation, attention, calculation, recall, and copying. Similarly, the frontal assessment battery was also giving a score of 10, which is below the normal cutoff, with impairment of lexical fluency, go-no-go test, and conflicting instructions. Then parietal lobe, the calculation was impaired. The simple calculations were normal, but complex calculations were impaired. That points more to a frontal lobe involvement also, because the simple calculations were normal. And also the constructions, as we can see here, the intersecting pentagons look grossly normal, but the clock drawing is markedly impaired, except for the normal contour that she has drawn. The numbers were all are all incorrect, and the placement of hands of the clock are also wrong, as well as copying of the cube also is a complex construction that is also impaired. Taking into consideration the grossly normal intersecting pentagons that she has drawn, I would like to think in terms of impairment in complex constructions, which would point more to a frontal executive dysfunction. Then occipital lobe functions were grossly normal. Language was normal. Recent memory was impaired, paired associative learning and recall impaired, suggesting a medial temporal involvement. Coming to the cranial nerve examination, we can see an impaired vertical saccades and vertical pursuit. So the up gaze was also restricted, but with more restriction of down gaze. So the vertical gaze was involved with involvement of RIMLF. Rest of the examination was all normal. The motor system as well as the reflexes, sensory system, cerebellar system, and there was no involvement of autonomic system as well. So to summarize, 54-year-old lady presenting with progressive neurological illness in the form of difficulty in looking down for 1.5 months, memory impairment, confabulation, visual hallucination, and increased sleepiness with focal seizures, and examination revealing involvement of frontal lobe functions, impaired recent memory and recall, impaired complex construction with vertical gaze impairment, predominantly saccades, and normal motor and sensory functions with no autonomic, cerebellar, or extrapyramidal dysfunction. So we have impaired episodic memory suggesting a medial temporal lobe involvement, frontal executive dysfunction suggested by impaired go-no-go test, impaired lexical fluency, impaired complex calculations, impaired clock drawing due to conceptual problem, and the marked down gaze palsy with suggested lesion in bilateral RIMLF. So the final site of lesion could either be a midbrain plus diencephalon or midbrain plus diffuse cortical involvement. The etiological differentials, as previously mentioned, I would like to consider the first possibility as a mass lesion, second one a paraneoplastic encephalitis like anti-MAT2, anti-neurobasets, cerebral Whipple's or CJD. So regarding the first possibility, I would like to consider a mass lesion in the upper midbrain, like a lymphoma, tuberculoma, glioma, or a metastasis. Second possibility, considering the vertical ophthalmoparesis, excessive daytime sleepiness, and cognitive dysfunction, anti-MAR2 encephalitis would be a possibility. The next one, anti-WHO encephalitis with vertical gaze palsy, cognitive disturbances, and seizures being her complaints. And third one would be a cerebral ripples, where we can have the abnormal eye movement, seizures, and cognitive impairment as we see in our patient. And fourth possibility of sporadic CJD should also be considered. The points for are vertical gaze palsy and dementia, but the odd point is that there is no history or finding of myoclonus in our patient. And other less likely possibilities I would like to consider would be a neurobiasis, but the odd point would be the isolated brainstem involvement in our patient. And then other less likely possibilities would be an adult onset Niemann-Pick disease, late onset GM2 gangliosidosis, and an adult onset Wilson disease.
Lakshmi? Sure.
So I want your expert comments.
Yeah. So in fact, myself and Ashwini prepared the entire topic together. So in fact, whatever she has said is our combined effort only. But only two, three points I would like to clarify. One of the in the high functions, she has got profound affection was a recent memory impairment, suggesting a medial temporal lobe involvement. But the same medial temporal lobe involvement alone need not be the site to cause a recent memory impairment, because its connection through the fornix and the hippocampal connection through the fornix, septal area, and the thalamic lesions all can produce recent memory impairment. One important aspect in this patient's history is the confabulation. In recent memory loss due to medial temporal lobe, they do not confabulate. Those who confabulate are usually due to the diencephalic memory loss, or they should be lesion in the associated frontal lobe. As there are two types of confabulation. One is the momentary confabulation, where any person with recent memory, they may fill up the blank space with events which just happened in the real life. The other is fantasy confabulation. They cook up stories and then bring out spontaneously. So here, both the things are there in this particular patient. So this can point to either more of a, rather than the medial temporal lobe, I would prefer a diencephalic memory loss rather than medial temporal lobe. And probably the connection between the frontal lobe also already has got frontal lobe involvement, that may be responsible for the confabulation as well. Now, the second thing is the construction approach. I was just telling actually that there is no definite evidence of parietal dysfunction here, because the so-called she has drawn a pentagon very clearly, but she failed miserably in the clock drawing, telling me that she has lost the concept of the clock. So that because frontal lobe is required for complex calculation, because you have to sequence the numbers, and also required for making a complex diagrams. So this sort of a construction problem can also occur due to a frontal exhibited dysfunction. So we need not necessarily implicate a parietal lobe in this patient. Thirdly, regarding the intact Bell's phenomenon, tell you that the upward is an upward gaze palsy, not a weakness of the extraocular muscles moving upward. That's very simple to understand. But here, the Srivardhan told there is a pursuit vertical pursuit abnormality. But actually, what happened, there is upward, there is a vertical pursuit abnormality is there. But downward, there is no pursuit abnormality. Why I'm telling so is that when you do the optokinetic tape downward, the eyes are moving down. That means the pursuit downwards is intact. Only the saccadic abnormality is affected. So actually, there is in this particular patient, there is a vertical, there is upward and downward saccadic abnormality. There is a vertical pursuit is affected, but not the downward saccade. That is why in OKN, on moving up, there is no movement, but on moving down, the eyes are moving down, but no corrective saccade backward. In lesions of RIMLF, you can have vertical saccadic palsy, both up and downward. The fact that patients got a pursuit abnormality in the vertical to upward direction also indicates that probably the lesion is affecting the posterior commission as well, because the pursuit pathway is going through the posterior commission. Need not necessarily be so. Even upper midbrain, the pursuit pathway can also affect that thing. But it is not, lesion is not confined to the RIMLF per se, because if in RIMLF per se, lesions will not affect the pursuit movement. Then calculation, these are the 2-3 points I would like to, I have thought that actually has paid to miss, I will to interpret. Otherwise, all other things is same as what actually said. I think we can open, when we can invite anyone for their comments, their suggestions, their different diagnoses. Lakshmi, if you permit, we can do that. And you are, you can't make a comment because you are, the case belongs to you.
Sir, what is your first diagnosis, sir?
I also thought, because everything, the starting with a vertical downward gaze palsy and not pointing to midbrain, the center of the lesion or the epicenter is in the midbrain. That is encroaching onto the diencephalon. So I would consider infiltrating mass lesion as possibility, like lymphoma. Other possibilities are paraneoplastic anti-MA2 antibody mediated paraneoplastic syndrome, because these features like a brainstem involvement, this thing and all can explain. Third is cerebral Whipple's disease. Because Whipple disease is very rare. There are one point, there's no gastrointestinal symptoms, etc. But these are, in fact, the same what I was, these are things which we have thought about this case. Same possibilities. In fact, we prepared the things together.
Sir?
Yeah.
As you'll see the, now I'll ask Srivardhan to present the image.
Okay.
And then we'll have a...
Before that, Lakshmi, do you want to invite some other comments from
anybody? It's open, sir. Anybody wants to add anything? Madam? Venkama, madam? Is madam there?
Okay, then we can go to...
Yes, sir.
Srivardhan, go a little slowly, eh? Don't run through the slides. Okay. You have to see the...
Coming to the investigations, her baseline renal and liver function tests were normal. Complete blood count was normal. Her ESR was 22 millimeters at the end of 1 hour. CRP was negative. CT chest and USG abdomen was normal. Serum calcium and serum AC levels were normal. Thyroid function test was normal. She was a known case of diabetes mellitus and HbA1c was 7.2, suggestive of a poor glycemic control. Coming to the imaging, this was a T1 coronal sequence where there is no gross abnormality which could be identified in the T1 sequences.
And don't describe anything. You just show the pictures.
Okay, sir. Yes, sir. So this is the T2 axial sequence. A close-up view of the T2 axial sequence. Flare axial sequence. Flare sagittal sequence. And a close-up of the flare sagittal sequence. And this is the contrast image, T1 post-contrast coronal sequence. That's with the images of this patient, sir.
No, Srivardhan, I want to say one more thing. Can you go? I want to see the pictures once again. Can you go back to the axial T2?
I'll do that, sir. This is the first image, the T1 coronal sequence.
Yeah.
T2 axial sequence.
Okay, just
close up of the T2 axial sequence.
Yeah.
T2 coronal sequence.
Just keep it for 1 minute. You can keep it there. So that
Yes, sir. Yes, sir.
Okay. Then go to the next.
Flare axial.
Keep it for 1 minute. Just 1 minute. Okay. Right. Next one.
Flare sagittal.
Can you have a coronal T2 to find out? I want to know the middle temporal lobe involvement. Coronal T2 is there? No. Coronal cut. Any coronal cut? Yeah.
I'm putting
Yeah,
a coronal T2 sequence now, sir.
Okay, right. Okay, good. Then a contrast MRI axial cut anywhere. You only showed one.
No, sir. We didn't have an axial image, sir. The only cut which was provided was the coronal sequence, sir.
Okay. Is it a contrast film? Are you sure?
Yes, sir. The sinuses.
Okay. But the parks, etc., is not enhancing. That's why I'm wondering. But it's really contrast. Right. Okay. So we'll stop at this point and get the comment from Ashwati and myself. I'll give the comment. Ashwati, you want to make any comment now?
Sir, before
Flares.
Yeah, Lishmi, what do you want me to do? Shall I go by step or?
no, but before we start the discussion,
Yeah.
all of you would have observed that the epicenter is the midbrain and diencephalic. Spot on. I wish all the participants should, give a big hand to them, because the clinical localization was spot on, and you could see that it's a really very, very good caliber clinical discussion, and it will be a lesson for all the youngsters to know that if you analyze the case properly, you will nail the anatomical substrate and look for it there. Sir, my hearty congratulations to Dr. Ashwati and you, sir. Sir, you are beyond. I'm really thrilled, and it's very, very happy, sir. We are congratulating you on spot on. Now you look at that. We'll just discuss the image.
Yeah. Actually, you want to discuss the image?
Sir,
Yes, sir.
the flare sequences show hyperintensity in the medial temporal lobe tectal area as well as the diencephalon area. Flare sequences.
What do you think the possible etiology you have in mind?
So the post-contrast films were not showing that much enhancement in those areas. That lymphoma, can it present like without enhancement?
There's no enhancement, absolutely no enhancement. Diffuse films are not given. No, and I will tell my opinion about the films. This lesion, as you said, is the starting in the midbrain, going to the diencephalon, involving the hypothalamus, middle thalamus, and some involvement of the temporal lobe, amygdala, and nucleus of the temporal lobe also. But the involvement is symmetrical. The symmetricity makes me suspect that it is unlikely for a mass lesion. The other point against mass lesion also the absence of enhancement. There are low-grade lesions can produce without enhancement, but these are rapidly progressive, only 1.5 months. Any mass lesion expects some enhancement, like lesions like lymphoma, sarcoid, or glioma, etc. So I think this is something else. I will prefer the anti-MA2 antibody-mediated paraneoplastic encephalitis. It will be my first possibility in this patient, seeing the MRI picture, because of the symmetricity and absence of enhancement. Let us see the subsequent investigations. Anyone else want to make a comment? They can make the comment.
There are a few questions.
Yeah.
Sir, there are a few questions in the question box. How to assess the occipital lobe when the patient has tubular vision?
You can easily assess the occipital lobe with the tubular vision, because if the patient got some amount of vision, you can easily assess the occipital lobe functions. Auxiliary functions are higher functions, no? Higher initial functions. No problem in assessing.
Yeah. And somebody, one student describe our nystagmus.
Yeah,
Please
this
describe
particular,
our nystagmus. That's what it was.
now this patient had, on looking, there's no nystagmus in this patient. What they observed was during the optokinetic testing, you can find that horizontal moving, the eyes are going, there's no optokinetic abnormality during horizontal saccades, horizontal movement, because when what they have observed is that the corrective saccade as nystagmus. There is no nystagmus as it is. Am I correct, Srivardhan?
Yes, sir.
Yeah.
Yes, sir.
Yeah.
Is
So that-
clock drawing not mainly for the parietal lobe?
yeah.
Somebody has asked, is clock drawing not the only main test for parietal lobe?
No, in fact, clock drawing is wonderful test for testing many aspects. You can test parietal lobe function, you can check the hemi-neglect and visuospatial orientation. And also, I think it's much more useful for testing frontal executive dysfunction. You can check defective planning and organization because they will fill the number, 12 numbers up to one point and stop. Or defective response set you can check because the patient go on number till the whole circle is completed, may number up to 40 or 45. You can check abstraction because if you want to say, ask the patient to draw a hand between 10 to 11, 10 minutes to 11, they draw a line between 10 and 11. You can also check perseveration because they go on with perseverating numbers. Three digit may be repeated 3 times, 4 will be repeated 2 times. So all these major executive function tests can be checked by the clock drawing. It's a very, I in fact tell you very frankly, in my bedside or in practice, I only do this 2 tests for frontal lobe because I don't have time for doing the entire thing. And one test is this one, clock drawing.
Sir, the seizures,
Yeah.
patient had considered diencephalon and medial temporal involvement. Is it,
Yeah.
since she had seizure, are we considering that?
Yeah, because exactly, because that's where the just adjoining the diencephalon is the medial temporal lobe. So the lesion must have extended onto the medial temporal lobe. Here in the coronal cut, you can see the medial temporal is also affected to extend, even though the epicenter is the diencephalon.
Sir, can it be, can we consider neurosarcoid in this case?
No, there's absolutely no enhancement here except symmetrical lesions. And the location is slightly odd for a neurosarcoid. Even the parenchymal lesions are known, they are patchy lesions. Usually neurosarcoid we suspect when it's adjoining the meninges, like dura or meninges or some suprasellar region like that. Those sarcoid occurring within the parenchyma are discrete patchy lesions and they enhance with contrast. Here there is a lesion which is as if it is spreading from the diencephalon symmetrically to both sides. That's not a pattern of sarcoid.
Sir, somebody has asked, can it be an acute diencephalic presentation of NMO?
That possibility cannot be ruled out. Only thing is that see that the evolution is 1.5 months, starting with vertical gaze palsy and slowly encroaching onto the adjoining sites. So I think that presentation is likely what for NMO, but I can't watch that it cannot be NMO. It's possible.
Somebody has asked, can it be a midline slow-growing glioma?
Yeah,
Low-grade glioma.
that's a possibility. The point which I said against all that, there's except symmetrically, the tumor growing symmetrically involving both sides without enhancement is a point against a glioma, more like something like an autoimmune encephalitis. Autoimmune encephalitis characteristically produce symmetrical temporal lobe involvement like this. For example,
Can be Wernicke.
Wernicke is possible, can produce mammillary body involvement, but this is not the picture they produce it. They produce not a involvement. Say they affect the dorsal part of the midbrain, periapical region, mammillary body, and the fornix. Intermediate areas will be spared. Here it is not like that. It's uniformly affected, and medial temporal lobe is also affected here.
So one specific question for you: what is the frontal lobe test you will do, sir? Madhusudan, sir.
Yeah, I already said the one frontal test I do is the clock drawing test.
Okay. So these are the few questions from the floor, and then Dr. Srivardhan.
Yes, sir.
You go ahead.
Just one thing we wanted to add in this focused up image, sir. There appears to be a relative sparing of the red nucleus. The T2 hyperintensity or the flare hyperintensity involving the midbrain seems to extend anteriorly or in the pre-rubral region, as well as extend slightly posteriorly with the relative sparing of red nucleus. And there is hyperintensity which is also extending into the optic tract. Again here, there is hyperintensity involving this part of the optic tract. So again, which can be seen very well here. So these are the two additional things that she wanted to tell, sir. And this was the image report provided by the radiologist. T2 and flare hyperintense and T1 isointense lesions involving the rostral midbrain, medial temporal lobe, periaqueductal gray, and hypothalamus extending into the optic tract. There is no significant mass effect. Lesions do not show contrast enhancement or associated with meningeal enhancement. Optic nerve and spine screening appear normal. MRA and MRV normal. Features suggestive of inflammation or demyelination to rule out NMO. Shall I proceed, sir?
Yeah. In fact, I did not see the optic involvement, frankly speaking, in the MRI. But since optic nerves are also affected posteriorly,
Optic tract, sir.
Optic tract, that can occur with NMO. That NMO possibility cannot be ruled out. But I will keep I will not, go away from my diagnosis of paraneoplastic, but I'll keep the NMO as also one of the possibilities.
So next is the CSF analysis. CSF glucose was 91. The corresponding blood glucose was 122. CSF protein was 72 milligram per deciliter, increased. Occasional lymphocytes less than 5. There are no atypical cells. HSV PCR was negative. Culture was sterile. Expert TB was negative. CSF VDRL was negative. India ink stain was normal. And CSF oligoclonal bands were negative. I'll mention the additional blood tests which were done. Serum aquaporin 4 antibody was negative. Serum anti-MOG antibody was negative. VEP, BERA and WEMP were all within normal limits. Our ANA showed a 2+. And when we did an ANA blot, anti-SSA antibody was positive. Schirmer's test was negative. Lip biopsy was also done because their anti-SSA antibody had come positive and there are features suggestive of CNS demyelination. But lip biopsy did not show features suggestive of Sjogren syndrome. ANCA was negative because of a predominant involvement of the brainstem or midbrain with the relative sparing of red nucleus. Even though the patient had no oral ulcers or genital ulcers, we consider possibility of neurobiopsy. Pathology test and HLA B51 were done, both of which were negative. And EEG was normal. Anything else you wanted to add, sir?
What about paraneoplastic antibodies?
Yes, sir. So with all these reports, it appeared like a typical syndrome. We ended up doing a paraneoplastic and autoimmune encephalitis workup. And the sample was sent to NIMHANS and their anti-MAR2 was positive.
Yeah.
Sir?
Yeah. In fact, the MRI.
Yes, sir.
Yeah.
So you are spot on from both the Ashwati and you both were spot on. But anyhow, we wanted to, for clinical localization and the everything was quite interesting. That's why we thought we'll choose this case, sir. And now I'll ask, sir, is there any other questions, sir? Any other things to add? I'll ask, otherwise I'll ask.
So the only point I would ask, the symmetricity of involvement was the thing which I was thinking more in terms of a paraneoplastic syndrome. The lesion was symmetrically involving.
Sir, HHV6 is quite symmetrical. That's what somebody.
Yes, you are perfectly right. My HHV6 is symmetrical. You're right.
So, anyhow, I'll ask Dr. Uma Maheshwari to talk something on the recent advances in this area.
Good evening.
Over to Uma Maheshwari.
Good evening, sir. Am I audible, sir?
Yes, yes.
Okay, sir. I'll just start sharing the screen, sir. Good evening, senior professors, colleagues, friends. Good evening, one and all. I'd like to thank my director for giving me an opportunity to talk here. And I'll just go into the brief presentation on the recent updates. So having come to a localization and the etiological diagnosis having been arrived, it's a case of paraneoplastic syndrome. The paraneoplastic syndrome.
Uma, come closer to the mic and talk.
Sir, am I audible, sir?
Yes,
Yeah. Now you're.
Paraneoplastic neurological syndromes, they are a group of disorders that are being associated with cancer, and they can affect any part of the nervous system. These disorders are not caused by metastasis or by local effects of cancer, but related due to the immune responses against the neuronal proteins. There are a group of classical syndromes which have got an underlying cancer, whereas there are also some less non-classical syndromes where the underlying malignancy is less. Onconeural antibodies. Onconeural antibodies are paraneoplastic antibodies. They refer to the antibodies that recognize antigens that are being restricted to the nervous system and to some cancers. And the classical onconeural antibodies, they refer to the antibodies whose antigen has been identified and whose gene has been cloned. There are a group of classical onconeural antibodies designated as anti-Hu, Yo, Ma, and a lot of other antibodies are there. And the nomenclature of these antibodies are being designated based upon, there are two different separate nomenclatures. That is the first one, the designation is being done based upon the first two letters of the last name of the index patient. That is Hu, Yo, Ya, Ma, all those goes to the first two letters of the last name of the index patient. The other nomenclature applied at Mayo Clinic is done based upon the staining pattern by immunohistochemistry. And then once the antigens for these antibodies were being identified, the antibodies were designated based on the antibody like anti-VGKC antibody, anti-NMDA antibody. There are a group of paraneoplastic syndromes pertaining to different axes of the neuroaxis, right from the brain up to the muscle. Group of classical paraneoplastic syndromes. I'll not go into the individual name. We'll just move out. And there is a diagnostic criteria to label this as a definite paraneoplastic syndrome. That is an association of a classical syndrome with cancer within 5 years of diagnosis of the neurological disorder, or a non-classical syndrome with a malignancy and improvement of the neurological syndrome after treating the tumor, or a non-classical syndrome with the onconeural antibodies, be it classical or non-classical, that develops within 5 years of diagnosis of a neurological disorder, or a neurological syndrome with an antibody, onconeural antibody, may be it classical or non-classified. Classical, just as our case, a case of diencephalic lesion with rostral midbrain syndrome, along with associated anti-MAR2 antibodies, that fits into the definite paraneoplastic syndrome. And it is a case of limbic encephalitis along with the rostral midbrain involvement. There is the presence of anti-MAR2 antibodies, and more than 90% of these cases are being associated with testicular cancer, lung cancer, and other cancers. The antigen is a MA1 antigen, that is a 37 kilodalton neuronal protein that has been identified in the neuron and the testis, and the gene has been identified and cloned. That's why it's being called as a classical onconeural antigen. Going into a few articles of this anti-MAR2 associated encephalitis. Anti-MAR2 associated encephalitis is a paraneoplastic neurological syndrome that is being characterized by clinical presentation of either isolated or a combined limbic, diencephalic, or brainstem dysfunction. And there is a case of about, among 38 cases, 34 cases were identified to have these association, of which the predominant manifestation was a combined manifestation of brainstem, diencephalic, and limbic. About 20 cases had a combined manifestations, whereas the isolated presentation of either a limbic, diencephalic was very less. And And just analyzing the 33 cases, positive cases, the neurological outcome in this 33 cases, that is analyzing the various factors. Male patients who had age less than 45, who had unifocal involvement, who had isolated MAR2 antigens, and who had an associated testicular malignancy, had a good neurological improvement on treatment when compared to the other parameters. And going through another article, that is anti-MA and anti-TA associated paraneoplastic neurological syndromes, which is being published the JNNP article in 2008. Here there was a comparison between the anti-TA, that is isolated anti-MA antibody versus anti-MA1 plus MA2. That is analysis of between these two groups showed that patients who had isolated MA2 antibodies, they had there was a special male predilection for involvement, and the age group was less than 45. The clinical presentation being limbic encephalitis or a combined presentation along with other cerebellar brainstem involvement. And the prognosis and the outcome of treatment was, that is the when it comes to the neurological syndrome, there was about 1/3 of the cases improved, 1/3 stabilized, and 1/3 deteriorated. And the outcome of the tumor was, there was a stabilization in about 95% of the cases. So going on to the treatment goals in this paraneoplastic syndrome, the first goal should be to identify and treat the cancer, and then go on to immunosuppression, T cell based suppression and B cell based suppression, and then to control the symptoms. That is paraneoplastic syndrome, or the antibodies being directed against either the surface or intraneuronal antigens. And the main treatment role is, apart from removing the tumor, is to be based against this antigens. The various immunosuppressive, immunomodulatory drugs available for treatment are steroids, intravenous IVIG, plasmapheresis, cyclophosphamide, rituximab, and other oral immunosuppressant drugs. Apart from that, a few words upon this paraneoplastic syndromes in the era of immune checkpoint inhibitors. That is, therapy with monoclonal antibodies targeting the immune checkpoints, including cytotoxic T lymphocyte associated antigen, the PD-1 and its ligand, has led to a paradigm shift in the treatment of this numerous types of cancers. Several monoclonal antibodies targeting these checkpoints have been approved with an expanding number of cancer indications, and this their unprecedented results in controlling tumor at a metastatic stage have come at the expense of an increased risk of developing the immune-related adverse events. That is, the immune check inhibitors addresses the anti-PD-1 and the PD ligand 1 receptor, thereby leading to the cytotoxic T cell damage of the tumor cell, bringing about the apoptosis of the cell death, and brings about aberrant expression of the surface and the intraneuronal antigen, which enters into the lymphatic system, and it leads on to it triggers the autoimmunity and brings about the expression of this paraneoplastic syndrome. So apart from this paraneoplastic syndrome, usage of this immune check inhibitors brings about a new problem, that is a paraneoplastic syndrome in response to immune check inhibitors are termed as neuroimmune response related adverse effects. In this setting, paraneoplastic syndromes can be diagnosed in 4 settings. That is, symptoms of neurologically immune related adverse effects is similar to classical paraneoplastic syndrome, or symptoms of neurological immune related adverse effects with onconeural antibodies, or an association with synaptic proteins or cell surface proteins. That is, aberrant expression of this antigens on the tumor cells leads to triggering of autoimmunity, resulting in this syndrome. There are a lot of drugs, that's immune check inhibitors, a lot of drugs are being used which targets the different receptors, and they're being used in a variety of malignancies, and this results in a syndrome that is similar to this paraneoplastic syndrome that's being called as neurological immune related adverse events. And when comparing the other autoimmune paraneoplastic syndrome, there is an increase in the MAR2 associated paraneoplastic neurological syndrome is being observed after treating patients with immune check inhibitors. Whereas there is a modest increment observed in other surface antibodies, that is NMDA, LG1, CAS, but there's a modest increase in all these syndromes being expressed. So management of this paraneoplastic syndromes occurring with immune check inhibitors is that suspected paraneoplastic syndrome in a patient receiving immune check inhibitors should be considered as grade 3 or grade 4 immune related adverse effects. And hence, when this is being diagnosed, this immune check inhibitors therapy should be continued and must be with steroids. And another thing is this chimeric and antigen-related T-cell therapy. This is a genetically programmed therapy in which the cytotoxic T-cells being programmed in such a way that they target the antigens over the tumor cells. And when this therapy is being initiated, patient develops a chimeric antigen-related T-cell related encephalopathic syndrome that is called as CRESS syndrome. This is nothing but a cytokine release syndrome in which patient develops fever, hypertension, and multi-organ failure. That is, treatment of this syndrome is with interleukin-6. So coming to the final conclusion, having seen about paraneoplastic syndrome, where there was a classical syndrome with a classical onconeural antigen, and still there is a search being for the tumor yet to be done. And coming to the management perspective, identifying the tumor, removing the tumor. Apart from that, suppressing the immune system either with an immunomodulatory or immunosuppressing drug is a treatment protocol. Apart from that, having the immune check inhibitors being the standard treatment for malignancies, that to patients with advanced malignancies being treated with this immune check inhibitors, there need to be an increased surveillance for this neurologically immune-related adverse effects complications. When this is being identified, the treatment with immune check inhibitors has to be stopped, steroids has to be initiated, and other additional immunosuppressive agent has to be used. Thank you.
Srivardhan, do you have the PET scan? Srivardhan?
PET is alone awaited, sir.
Okay. Anyhow, sir, we have done. I'll update you for all of you about the PET scan the next meeting, because the patient is still there in the ward. We have fixed a PET scan for evaluation, and my sincere thanks to you, sir, and hope all of you.
Thank you, Lakshmi.
All of you enjoyed. And sir, Professor Sudhisha, sir.
Yes, Dr. Lakshmi, please go ahead. We must give a really standing ovation for Professor Madhusudan sir, and of course for the team. It was a wonderful discussion, and I mean, every time he proves that he's a master clinician and a master teacher. Heads off to you, sir, and so nice. We would like to have you again and again. Dr. Lakshmi, you may please finish the remaining formality and thank everybody. Yeah.
Sir, my sincere thanks to Professor Madhusudan sir, as usual. He was spot on. And my sincere thanks to Ashwati Sashidhar. And I could see glimpses of sir's teaching in her way of discussion. And I'm sure that she will become one of the greatest clinical neurologists in future. My hearty congratulations to her. My sincere thanks to Dr. Srivardhan, Professor Balasubramaniam for sparing the case for discussion from his unit. My sincere thanks to Dr. Uma Maheshwari, who had highlighted on the recent advances. My sincere thanks to Dr. Srivardhan for presenting this case. My sincere thanks to the Professor Sudhir Shah is always an inspiration to me. And thank you so much, sir, for inspiring us for this program. My sincere thanks to all the doctors who have attended, sparing their valuable time. My sincere thanks to Professor Venkamma for attending such senior neurologists like Professor Venkamma. It's an honor for us for attending this, madam. And my thanks to Arun Chadda and team, and Manoj and Heli have done a wonderful job. Thank you so much. before winding up, April 30th, our scene moves to Vizag, where Dr. Buchi Babu will take over the discussions along with his team. And on April 30th, last Friday, 8 o'clock, we will meet again with another interesting neurological. Over to Arun Chadda and team. Thank you. Good night.
Before that, Lakshmi.
Thank you,
Yes,
thank
sir.
you, thank you, sir.
Yes, sir. 1 minute.
Lakshmi,
Sir,
one day. Now, I would like to thank Sudhisha and Lakshmi for inviting me to give me the opportunity to partake in your Secrets in Neurology. It's the first time I am coming here. If I had known earlier, I would have attended the programs regularly.
so we'll give you the programs. Don't worry, sir. It's all, sir. Each time every time.
Yeah.
The clinical, I was really, each institute we are giving, sir.
Okay.
I have seen each one trying to peak the other one, sir.
Okay.
Last time, I was so happy that in Ludhiana, they demonstrated how to do a diplopia chart and the various eye movement abnormalities, how to do. And there was a wonderful paper, I will send it to you, where the MRI localization of RIMLF and each nucleus where to look for. It is a wonderful representation of the various ocular movements and clinico-radiological correlation of that, sir.
Okay.
And
Very good.
few of them are really worth remembering. It's a real treat for all of us, sir. And I'll share those things with you. So nice of you, sir.
Thank you, Lakshmi. Thank you. Thank you, sir.
May I add to
Thank
that, sir, Professor Madhusan, sir,
Yes.
it is great that you have now joined our team, but henceforth you be with us and give your critical comments. We would really appreciate that. That is one thing. And second thing, sir, this is a way to preserve our clinical neurology. It is a kind of master class. So we have preserved all those previous webinars, and if you so wish, we can pass on this as archives. But I can tell you, this is such a wonderful and high-level program that each and every one of us learns every time. So people like you around, we would be really riveted, and your presence is most requested. Thank you very much. And finally, also spread the word to other people so that we can have.
Yeah, sure. Sure.
Sir, the orgasm you get when clinico-radiological correlation happens is really enjoyable. So whenever, when you make a clinical localization and see the lesion in the same site, you really get excited. That is where the charm of clinical neurology lies. I would anyhow, thank you so much. Thank you, and over to Arun Chadda and team.
Thank you, sir. Thank you, sir. Thank you. It's really great that we are at the end of the 9th session of Secrets of Neurology. Web series turned out to be very successful, and I, Arun Chadda, Senior General Manager on behalf of Intas Pharmaceutical, would like to pose a hearty vote of thanks to all the honorable delegates who blessed us with their presence, and its audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to thank our Honorable Course Director, Dr. Lakshmi Narasimhan sir and Dr. Sudhir Shah sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. A million thanks, sincere thanks to Dr. Madhusudan sir for the sea of wisdom and knowledge sir has showered to all the DM and DNB students with your expert comments and explanation given to each and every. You are too excellent. I would like to thanks to our young neurologist, Dr. Shri Vardhan and Dr. Chathi for presenting the case. Further to this, I would like to thank today's entire faculty, Senior Assistant Professor Dr. Uma Maheshwari, ma'am, and Dr. Madhusudan sir for presenting such a unique case discussion with fabulous presentation, which will be extremely helpful and into all the participants. Great presence, and it's being a pleasure being with all of you today. Thank you all for your patience, and I wish you all a very good night now, with a promise that next 30th April 2021, we will meet with the most awaiting next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you, sir.
Thank you. Thank you. Good night.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir.
Thank you, Lakshmi.
Thank you.
Yeah.
Good night, everybody. Thank you. Thank you very much.
Thank you.
Thank you, sir.
Dr. Chandra, kindly call me back after the